Hello, everybody, and welcome to today's webinar, No Surprise Act and the Requirements for the Good Faith Estimate. My name is Sabrina McCarley, and I will be moderating today's webinar. And NARA is very excited to have with us today Nancy Beckley and Courtney Lishka. Before I turn it over to them, I would like to cover a few housekeeping items. All participants have been placed on mute for today's webinar. We are also recording the webinar today. A link to the recording as well as the handouts for today's presentation will be provided to you in about 48 hours for everyone who registered. The link for the recording as well as the handouts will also be available on NARA's member portal. If you experience any technical issues during today's webinar, we ask that you please type those into the chat box as Christy is monitoring that and she will be able to assist you. If you have any questions for Courtney or for Nancy, we ask that you please put those into the Q&A box and we will get to those at the end of today's presentation. So with that, Nancy, I'm going to turn it over to you.
Thank you very much, Sabrina. I'm really excited to be here today. And thank you for introducing my colleague, Courtney Lishka. Laura couldn't be with us today. And so I want to introduce Courtney to you. I've worked with Courtney for quite some time. She's a compliance up and comer at Mountain Land Rehab and has been a mentee of Laura's. And I'm especially glad that Courtney's here with us today because she probably won't tell you this, but I'll tell you, before Christmas, she had brain surgery. So we're really excited to see her back. And, you know, she's kind of almost sort of back to normal, right, Courtney? So
almost, you might get a little winking at you. It's the paralysis.
Okay. All righty. Well, thanks for being with us.
Thank you. I'm so glad to be here with you, Nancy.
All righty. So today we're, going to talk about the No Surprises Act. It caught the therapy community by surprise. And the interim final rule with comment, which was, issued late September, early October, included a definition of healthcare provider and healthcare facility that implicated compliance. And we kind of are sort of struggling with what happened with that. How did that fly under the radar? And we're going to tell you a little bit about that. So this webinar is all about, are you ready to be compliant by going through the rules? So we've got here what we're going to cover in the webinar today. I won't read all that. Sabrina's told me I'm a good webinar presenter because I don't read everything on the slide. So I want to stay true to that. So you saw that we went through our narrow housekeeping. Now we're going to go through the No Surprises Act, the regulatory information for about 20 minutes. We'll do implementation, which Courtney's been on the implementation team for about 6 weeks now at Mountain Land Rehab, and do some Q&A. So I want to thank Mountain Land Rehab for sort of being a test pilot on this. Laura and I participated as advisors to the APTA PPS special task force that was dealing with. And we've been in contact with a compliance attorney, Kim Stanger at Holland and Hart, who allowed us by permission to use some of the tools, which we'll get to. So here we go. I listen to the NARA town hall meetings every time they come up, and we had another one last Friday. And you just think, how long can this keep going on? We're still dealing with the payment cuts. We're still trying to forestall or push out into the future the assistant modifier. We had a huge discussion about telehealth at the NARA town hall last week about trying to find out how we can get in and what are examples of reusing the remote monitoring codes. And then we've had the CMS mandates. We'll have another webinar on that coming up in 2 weeks. But today we're going to talk about the No Surprises Act. And I don't know why the bright white arrow, but it just seems appropriate that be somewhat of a positive thing in all the mess of this. So where does the good faith estimate fit in? Because it's the good faith estimate portion that's triggering the reason for this webinar today. All of us probably got notices, especially if you follow the regulations coming out of the No Surprises Act. There was a Part 1 rule, earlier this year with comment period, and then there was the Part 2. So we're going to talk about the good faith estimate, and it fits in with the Title 45, which is not CMS. Remember, we're at 42 CFR. So we're at 45 public welfare, all the way down through the Department of Health and Human Services, surprise billing and transparency. We're at 149.610, which is the provision for the good faith estimate. And then 149.62, which is the provider dispute. Those are the big things that were published in the Part 2 interim final rule with comment. which the comments were due, by the way, by December 6th. So in addition to this interim final rule that was issued jointly by all the various departments, which I'll give you a heads up on that on the next slide, that HHS provided additional context of the good faith estimate that's not in the other rules. So this is kind of where we're sort of taking a departure from all of the people that were in on the part one, the big picture, the Office of Personnel Management, our good friends at the IRS, the Department of the Treasury, Employee Benefit Security, Department of Labor, and last of all, Centers for Medicaid and Medicare Services, which we all know is part of HHS. I want to point out in the presentation, we've done an extensive citation on every single slide. So this is a learning tool. Take it back, the slides are hyperlinked in terms of the PDF, which you'll be able to get. But this is the big picture of the legislation of what happened in part one. So you can see the algorithm that we're going down and everything that's involved. And we're dealing with the way at the bottom, the 149.410 at the bottom. CMS has provided resources for providers, but like we all know, when you get to the CMS website, it's sometimes a little bit difficult to try to determine where to go to find the exact thing that you want to do. If you've ever looked up stuff on HIPAA or Section 1557, I think you probably know what I'm talking about. You sort of have to know where to go to use the right references, but this is a great resource page. CMS is continuing to update this. On the page, you want to take a look at policies and resources, not the part for consumers. And also CMS has two different slide presentations posted, and a good one to take a look at is the one that I've noted on the right, the overview of the Public Health Services Act provider and facility requirements. So a few disclaimers here as we move forward. It's informational only, and it's not designed to provide legal or consulting advice. We're only going to be dealing with subpart G 149, 610, and 620. As of today, our information is current. We went back and took a look and saw if anything was coming out. CMS promised to put some additional resources out. We haven't seen them. And if you have some concerns or issues for the provider setting that you're at or the state that you're in regarding some specific state guidance, we encourage you to seek your legal counsel for specific guidance and applicability to your practice. And I know many providers have done that. I hear a lot from people that are in the cash community. And quite interestingly enough, since this is designed for people that don't have insurance or pay cash, the therapy cash providers say this doesn't apply to us. So go figure. That kind of conversation is already going on. So I mentioned that this started in the summer with the No Surprises Act Part 1 and some key takeaways. And you got a link at the bottom there to go and read all of this information to your heart's desire. We have. So we have a kind of a sense of where we're going. But this was that part this summer where we all looked at it, at the compliance folks in rehab, and said this doesn't apply to us. They were dealing with the issues that came forth from emergency rooms where a person went to an emergency room, and you may have experienced this in your own family. You step into an emergency room, it's an in-network facility, or your insurance covers it as an in-network facility, but the person that read your radiology films was not an in-network provider. It could have been just not always, or maybe not that day. So this was the whole particular process for Congress and all of the, all of the other federal agencies trying to get involved in this particular process. So now we fast forward to part 2. And generally in part 2, it's providers and facilities and providers of air ambulance services. And I'm going to stop and say they keep repeating the term air ambulance services, which make a mental blackout on that, redacted automatically. That's coming up all the time simply because it was forgotten to be stated in the part 1 rule. So we're seeing it repetitively happen. And I think that's been a little bit misleading for people and saying, well, this is about air ambulance, and we're not an air ambulance service. So the particular items in the requirements for the good faith estimate do not apply to beneficiaries that are enrolled in federal healthcare programs. So that includes Medicare, Medicaid, Indian Health, Veterans Affairs Healthcare, or TRICARE. And according to the rule, this is because they have other protections against high bills. You'll notice now this is the first variance in the red where we're describing federal healthcare programs and not in just limiting it to Medicare, Medicaid, and TRICARE. So for the purposes of this rule, this is the first time we're going to see federal definitions vary from what we have come accustomed to know. So as you're reading through the rule, you sometimes have to erase what you already know about the definitions. So in part 2, what we're coming away with is we have to, as providers, provide a good faith estimate in advance of the scheduled services or upon request for uninsured or self-pay individuals. And those are going to be definitions we'll be taking a look at too. So in terms of a comparison between what happens in part 1 with balance billing and what happens in part 2 with good faith, the differentiation is on the screen. So if you have people that are saying to you something that is related to balance billing, it would be helpful for you to know what are the balance billing requirements. Certainly personally, you want to know them, but also to have a good understanding where it fits at your practice. It's limited in scope. So keep that in mind. And generally speaking, therapy is not going to be in that scope. A good faith estimate applies broadly to all healthcare providers, and the law requires providers to give all uninsured and self-pay patients their good faith estimate when they schedule an item or service, or if they request a good faith estimate. So it relates to all services. I'm going to just use the word services, and we must identify the cost of those items relating to it. Now, we may need to coordinate with other providers. We may be a convening provider, or we may be a co-provider. For the purposes of continuing to go through this presentation, keep in mind, for the most part, therapy practices, rehab agencies, because this is the National Association of Rehab Agencies, they're probably not going to be a convening provider that's going to coordinate other people. So as we go through this, we'll give you further clarity to those definitions. So a good faith estimate's not binding. However, the patient can challenge it if it's more than $400 out of whack. So that seems kind of interesting. We don't hear about stuff that's not binding, but we hear about an opportunity for a patient to formally raise a complaint. So how we all became aware of this is while we were moving into the holiday week in December, APTA published a practice advisory and sort of dropped a little bit of a bombshell. At the same time, the National Association of Social Workers, the American Psychological Association, and the American Associations of Mental Health Counselors and other groups of that type published basically the same type of thing that APTA published. I want to, mention and have everybody keep in mind that the interim final rule with comment came out September 30th or October 1st, somewhere in that vicinity. And the comments were due by December 6th. So notice that the APTA document came out on the 20th. AOTA didn't make a comment till the 4th of January, and ASHA came on board on the 21st. So it caught everybody off guard, and there really was not a response from therapy practices or therapy organizations such as we might normally do as NARA to this. So it caught everybody by surprise. There was no response. And that's unfortunate because now we're flooding CMS with questions on the applicability. I'll go through, we'll go to each one of these pages. I'll show you a link to all of them, but the APTA document is a members only. So likely somebody at your practice or rehab agency is an APTA member and you can get the advisory. The advisory is largely repetitive of the law and what we're going to cover today. AOTA put out an advisory, and I've got the link on another slide, on January 4th. And said essentially in a limited version what APTA did. And then ASHA put out a missive a few weeks ago and gave a couple of templates. So that's kind of the starting point that we're going to go through right here. So I call this confusion, finding a way out. Both Laura and I decided to dig into this the very minute the APTA practice advisory came out, and we contacted a pretty tight-knit group of compliance people. Many of you know them. We contacted Helene Farron, Rick Owenda, Robbie Leonard, Mary DeLong, and said, what do you think? Well, we'd worked extensively with Rick before Christmas. Other folks were on vacation, and we continued to convene on this and talk about some of the different items on this and what it means and what we need to do. So some of the issues that come up and when we take a look at the rule is when we're in Medicare, a provider is a rehab agency and a supplier is a private practice, and a facility is also a provider from a Medicare perspective. So we've got unique definitions in Medicare and CMS that don't match up with this rule. And remember, this rule had multiple other authorities to it, so that they didn't sincerely apply Medicare definitions. Then we have the whole confluence of what is self-pay versus uninsured. Many of us in therapy think of uninsured people as people that might be charity care. We don't necessarily think of them as cash or self-pay. So we've got some definitional items. So we have period of care in this definition versus plan of care. So if you begin to see POC, you might start thinking plan of care because that's been drained into our brains forever. Then we have the issue of cash versus a cash practice model. So the definition of cash may not be what's in your mind when you're thinking of a model of practice that is cash. And the issue of uninsured versus charity care versus hardship, and the issue of somebody choosing not to use their insurance. And if you are contracted with an insurance company, can you choose not to have the patient use their insurance? And that might be a contract issue. The issue of the patient's choice not to use their insurance, because that's one of the questions you ask them. Do you have insurance? Will you use your insurance? Invokes the whole conundrum of, with Medicare, the mandatory claim submissions rule. And you can't just simply say, I want to pay cash for my Medicare covered services. And any other contractual obligations. And probably, I think one of the wild cards is what is wellness. And there is a whole sense of therapy that's not rehabilitative versus not maintenance might be wellness, but we have to take a look at some other definitions to arrive at that. So we've got a little bit of a confusing pathway as we move forward. So in determining if it applies, since that was the first question out of the box when we started hearing from people, shortly after the new year, when there was somewhat of a widespread panic among what I'm going to call the private practice community, and that could include traditional brick and mortar rehab agencies. It's always great to take a look at your Practice Act and the administrative rules in your state. Always good to refresh yourself. A good way to get quick to it for physical therapists is to access the various state resources through the Federated State Board of Physical Therapy. The link is right there. Great source. If you're a speech language pathologist, ASHA provides state requirements and contact information in each particular state. Now you'll have to do a few more clicks, because when you get into each state, you'll have to click down for the Practice Act and the license. But you may want to avail yourself of what those documents state with respect to your license, working under your license, and if there's a definition of wellness and so forth. I could find no such document for occupational therapy. I did reach out to Sabrina, and she was reaching out to AOTA to see if there was something that we could avail ourselves of. So since there's not a central location to access in to AOTA's routes to get to your State Practice Act and administrative rules, I just put a clip in here to the AOTA notification that they put up on the 4th. So if we get any further information from any of our OTs that are on our call today, we'd love to update the presentation. So now we get into definitions, and this is really an important consideration in the application of the No Surprises Act. And I want to kind of liken this to is when we take a look at definitions in Medicare for different sites of service. Probably a really good example of there's a different definition of group in skilled nursing facilities, Part A, than there is in Part B. And so we have to pay very close attention to the definitions as we're moving through here, as you do with any law. So starting with who's a convening provider or a co-health provider. The convening provider or facility, and that's going to be us as a rehab agency or a practice, who receives an initial request for a good faith estimate, from a pending patient, a patient that's referred or is going to schedule, is the party that would start the ball rolling and potentially add other people to the estimate. Once again, I'm going to operate from the assumption that most in rehab are not going to be having that particular choice. It's going to be one and done. The rehab agency or the practice is going to be the one that's going to be initiating it. And a co-health provider or facility, so they would be parties that might furnish items or services customarily provided in conjunction. There could be some scenarios there. One of the things that Laura and I did as we were putting this together was try to brainstorm a bit on what those might be, but I don't want to necessarily call all of them out here to distract from going through the content, but we did contemplate some of these. So an expected charge, and this is a pretty important one because we like to use the term, what's my fee schedule, what's my charge, what's my cost, what's my reimbursement? Well, the expected charge for the definition of a good faith estimate is your cash pay rate or your rate established by a provider or facility for an uninsured or self-pay individual, including a discount. Courtney's going to give a little bit about that and how they handle things at Mountain Land. They have a perfect example of how this comes into play. So once again, we have to follow the definition of expected charge here for what we're going to put on the good faith estimate when we get to it. And the actual definition is a notification of expected charges for a scheduled or requested item or service. And I guess an item could be somebody could come in for an orthosis, but I think most of us in therapy would call that a service too. So that's the definition of the good faith estimate. So now we have the variance here that we have a healthcare facility, which we're all accustomed to a rehab agency falling into that loop when you make a Medicare application, the application of Section 1557 and other rules all come about because somebody's a healthcare facility, and that's called a provider in Medicare. However, in this law, it's not, and it doesn't include rehab agency in that cluster up there. They define healthcare provider, a physician or other healthcare provider acting with the scope of practice of that provider's license or certification under law. And this is, I'll leave that there just to kind of sink in for a second. This was the triggering event that caused, APTA, the Psychological Association, the National Association of Social Workers, to essentially put their guidance out there late in December as to the applicability. An uninsured or self-pay individual, once again, lumping it into either or, is an individual that doesn't have benefits for an item or service. Now, think about that for a second. So if you are in Medicare, and we're going to give this example, but Medicare doesn't provide a benefit for an item, that means that you're in a health plan that doesn't have benefits for an item or service. Now, we're testing some of these assumptions with CMS. So you see, we're kind of moving into terminology that is by law we have to follow versus what we've become accustomed to maybe using anecdotally in our practice. And then alternatively, somebody who has benefits but chooses not to use them. Now with Medicare, if you have benefits, mandatory claim submission, so that's not an issue. If you have a benefit for a Medicare medically necessary covered service, you have to use your benefits. So now we have a situation where somebody's saying, I don't seek to have a claim for such item. And Mountain Land came up with some scenarios that Courtney's going to tell us about a little bit later of people that invoke that particular rule in kind of a unique situation. Period of care is the day or multiple days for the period of time that the good faith estimate is good for that selected or scheduled or requested item. Now, it might seem like, gosh, that could coexist with plan of care. And actually, we don't want it to coexist with plan of care because the plan of care has very, very different governing regulations. And we want to follow all of the rules for plan of care certification, what's required when we make a modification, a minor to a plan of care, and what's required when we make a major modification in those timelines. So once again, this is the last of our confusing definitions. So we're going to step into implementation. We're going to look at a sample checklist. We're going to talk about stakeholders, policies, and processes. And I'm going to let Courtney start up with this particular section right here and take it away.
Great. And as I go through this suggested implementation, it might be helpful for you to think about who on your team is going to help you accomplish these tasks, how they need to interact with one another. So at Mountain Land, we put together a task force that included, marketing, operations. You'll have different terms, but as you hear the requirements, I suggest you keep that in mind. It will help you to execute. So the first part obviously is just to post the notice. There's some specific language. It should be on your website. It should be in your office and anywhere that scheduling or questions about services occurs. So if you have somewhere on your website where someone can request an appointment, the language or a link to the language should be right on that page. And of course, you need to just ask patients if they're self-pay, because that's the trigger, right? As soon as you have a patient that's self-pay, you have some obligations. Once you have identified a self-pay patient, you want to inform them that they have the right to obtain a good faith estimate. So this should always be in the language spoken by the patient. So that's a tricky thing that you want to be aware of. And this is also going to explain all of the things that will trigger you to need to create a good faith estimate. So first of all, of course, if the patient asks about the cost of services, we have determined that that is the same as a request for an estimate. Of course, if they do outright request the estimate, you want to generate it. And then as soon as self-pay services are scheduled, you should also create that good faith estimate and send it to them. It's not required for emergency services, but of course that doesn't apply to most of the rehab community. You also want to make sure that the elements that are required are on your estimate. There is some specific language, so you'll want to review the regulation and make sure you pull all of the required language. Just like they have a sample form on the HHS website, there's also some required data elements. So if you're going to adapt that, you need to make sure you have that chart of the required elements so that you're not leaving off anything that is essential on the good faith estimate. And if it's inaccurate, it might limit your ability to collect. There is a dispute resolution process available to patients. One of the things that we have done actually to facilitate the timeliness of this and the accuracy is to make some templates for some of our standard services. So Nancy kind of alluded to this earlier. One of the things that we did to simplify was to take our self-pay and combine that with our cash rates. So that's actually the only way that we handle self-pay, and that made it much simpler, so we can make some templates that just described what our cash rate services are. So we can get to that information really quickly at the front office level. On the good faith estimate, you do need to provide an option, either paper or electronic. So we have the option to just send an email, or we can print it up. That estimate does need to be provided within specific timeframes. So if they are scheduled more than 3 days out, you have just a day to get that to them. If they're scheduled more than 10 days out, you have a little bit more time, or if they request it, you have 3 days. So this is a really short timeline for you to gather information that is intended to be very accurate. So as we think through this, think about how you're going to accomplish this. Who is going to implement the process? Where schedulers can generate and send something out right away. Then we know that if you anticipate changes, you should reissue the good faith estimate. So whether that's going to be change in services or change in the provider that's providing the care, if it will affect the estimate, you should render a new one to the patient. Now, if you miss a deadline, issue it late and examine your processes to rein in those delays. But don't let that stop you from meeting that obligation. And of course, recurring estimates are helpful. We can do that for up to 12-month periods. So again, we go back to our cash rate basis for self-pay patients. We're able to issue a good faith estimate that describes that every one of their subsequent visits is going to be a certain cost. And one of the things that you need to do as well is maintain a copy of this. So you not only hand the good faith estimate to the patient, you also put it in the patient's medical record. You do need to retain that for at least 6 years. And also you have to give it to the patient if they request it again. So anything that you have handed to the patient previously, if they request it, you need to be able to provide that to them as part of their medical record. And HHS has also determined that currently they're not going to enforce the co-provider rules, but if that is something that applies to you, then you need to be prepared to comply by 2023, as long as nothing changes. And of course, as always, update your policies and procedures to reflect that your processes are in compliance and that they're accurate to what you're doing to comply. And one of the things that we did here was try to think about where can we update current policies to include the good faith estimate language so you're not recreating the wheel. You know, this is related to so many of our other processes as we are currently existing. Here is our website, Mountainland Physical Therapy and Rehabilitation. We have posted our good faith estimate language at the bottom of our webpage, right next to our No Surprises Act. I'm sorry, this is the No Surprises Act language next to our compliance and our privacy policy and other details down there. We also have a page where appointments are scheduled. It's posted there. So that link will take you to this page that has the full language that's required. And so they have the information that they need to have. We're actually going to add a link here as well, where they should be able to just fill out a web form to request a good faith estimate. And that will go to a central location where someone can gather the information they need and generate that for them.
Courtney, don't you already use web forms at Mountainland? Weren't you trying to, what format do you use for your web forms?
Yeah, we sure do. So actually, one of the things that we are going to do is use the web form to request an estimate, but we also use electronic forms, and that's how we're going to generate it as well. Mm-hmm.
So then you're going to avoid the tedious stuff with the CMS paper form and whatnot. Let's go ahead and take a look at the process that started in like December 21st with Mountainland. And this is a call script. You want to take us through the call script and how it's evolved? This is the first call script example.
Yes, absolutely. So this was actually Laura's brainchild. She's so good at making sure we're asking the right questions and getting to the information. You can tell it was written by a compliance officer though, right? Because that's not really how you speak to your patients. Are you calling to schedule? But it does get you to exactly where you need to go. And so what we're going to do is we're going to take this call script that ensures that we're asking the right questions and finding out if we need to evoke that we are obligated to create an estimate, and add the language that we want to use, you know, conversationally. So we're going to marry this document with our front office trainers and make it something that's living and breathing, but that way it's a process, it's a flow. Everybody has the same language and they can, you know, have the tools that they need to make sure that we're fulfilling our obligations here.
You know, so for example, if one of the PTs happens to be answering the phone and covering the front desk on a snow day, well, in Wisconsin, it would be a snow day, not maybe so much in California, but they would be able to go according to the process here and not just, you know, sort of mess it up, so to speak. So
right. Yeah, absolutely. Because we're obligated, no matter who answers the phone, if a patient's requesting information about cost, we're obligated now. So we need to make sure that this is trained across the board. Anybody who could be answering the phone, we should have something available, a resource for the people who maybe aren't answering the phone all day long.
Mm-hmm. And then of course, as the law said, they will consider any discussion of price as a request for an estimate. So the patient doesn't have to invoke that particular term.
That's right.
Okay. Now, CMS provides the data required elements. If you take a look at the diagram on the left, and it's a couple pages long, then on the right is the CMS paper and pencil form. And I call that so old school. It's just amazing, I think, to all of us that CMS would come up with this kind of a paper and pencil form. Of note, we went through this several times and matched everything up. CMS forgot a couple of the things that are required in their own form. So it's kind of one of those things where you have to continue to go through this and determine if you're getting everything. Now we mocked up an Adobe Acrobat form that is a fillable form. And if you're using an electronic Adobe Acrobat at your shop, it becomes a point where you can actually have the patient, like, many of us sign other documents these days that we have to affix our signature to electronically one way or another. So in this particular type of a form, everything that's required by CMS, we put on there, but we configured the form for therapy because we understood that there were unique things related to therapy, and we did it as a single provider. We'll go through a little bit more details with the form as we continue to go through. Courtney, you want to run us through the disclaimers that we need to have?
Yeah, sure. Well, I mean, you've got it out here really, really clearly. It is based on information that's known at the time the estimate was created. So, if you're doing an initial eval estimate for someone, you can't necessarily describe what each of their subsequent visits are going to be because you're not sure yet. So again, that goes to where if you have an update, you want to go back and update your good faith estimate. It's not a contract. Okay, so like I said, it's not binding, but if there is too much of a discrepancy, we know we go back to we could potentially go to the dispute resolution process. Additional items and services that are not on it can be recommended. So, if there's bans, other stuff like that, it does not have to be reflected on the good faith estimate. And it does not include any unknown or unexpected costs. So if something comes up, this is really, think about that this is geared a lot toward hospitals and stuff, but sometimes things happen that aren't expected, and that it's okay. It's okay if that wasn't included because you didn't know.
Yeah, you will have a chance to correct it before the patient disputes it. So here we have another page of disclaimers, a lot of disclaimers.
Mm-hmm. And you do have the right to dispute the bill, and you can ask them to update the bill to match the good faith estimate, negotiate the bill. This is the patient, sorry. So if they're billed more than what they expect, they have these rights. Financial assistance is available. They have to ask if financial assistance is available. You may also start a dispute resolution process within 120 calendar days if the actual bill charges are more than $400. There is a small fee to start the dispute process, so that's kind of discourages people to do this if it's not really an issue. I think that's a good point. The agency reviewing dispute agrees with you, you will have to pay the price of the good faith estimate. So if they're saying that you're right, this estimate was not provided in good faith, it wasn't accurate, they billed you way more than they should have, the patient only has to pay the amount that you told them they were going to have to pay. If they disagree with the patient, then they will end up having to pay the higher amount that you're billing. So if it was truly in good faith and the extra charges were unexpected and you couldn't have foreseen them, then it's possible that the dispute resolution will still allow you to collect. Just certainly makes it more difficult. And then of course they give you information about how to contact the Department of Health and Human Services, and they tell you to keep a copy of the good faith estimate. So if they
what's instructive on this is the AHA and the AMA have both initiated lawsuits regarding this. The lawsuit's not about the good faith estimate, it's about the dispute resolution process. Remember, we talked about the Part 1 rule. The Part 1 rule contained the formula for arriving at the good faith estimate in a dispute. What is the price that was going to be paid? And there was an expectation on the part of the biggies, the hospitals and the doctors, that would be calculated at a certain level. And CMS in the first rule calculated it a little bit differently, very lower, and both associations were afraid this would actually lower the in-network rate. So they made their comments. They thought all was hunky-dunky with CMS. Then the Part 2 rule came out and CMS said, no cigar. So they didn't do the changes. And so henceforth, that's why the rule is being disputed. So if you hear that it's being disputed, it's based on good cause for the dollar amount where it fits in the service spectrum of the average cost of the service. So we have a custom form. This is page 2 of the custom form that you saw that Mountain Land is using. And as Courtney said, many providers have form tools. They have many at Mountain Land that they've constructed. Many of them are posted to their website for ease. The patient can go on board and electronically file things out. And so we have to, on a good faith estimate, making sure that we're getting these type of items and forms all back into the system and directed to the parties. It may look easy, but Courtney, I think you're finding out the process was a little bit more complicated than you thought.
Yeah, I think it was more complicated to interpret and be able to pull together what different types of forms we were going to need than we originally anticipated. But we did, look for ways to integrate and create simplicity. And we simplified by creating policy linking that cash rate to our self-pay rate and the good faith estimate. And so, and then we also boiled the forms down to what we really needed to get to. And we actually took them out of Adobe and put them into an online electronic form so that we go to a space, input information, and it kind of spits it out now. But the building of it really is more complicated than at first blush.
Mm-hmm. And that's so that you can keep it electronic. If one wanted to just keep with the paper and pencil, you could have somebody sign it and scan it into the EMR.
That's right. And our forms actually are printable as well. So we plug it in, we can either print it or email it to them.
So what are your recommendations, having said about 6 weeks and kind of orchestrating some of the processes at Mountain Land?
Yeah, well, certainly document the steps you're taking. We know that this caught everyone by surprise. So people are scrambling to catch up. We were supposed to be compliant January 1st. Not everybody is there yet. So document the steps you're taking, the good faith efforts you are making to comply with the good faith estimates. And that's always important. You also want to make sure to identify accountability. We talked about that a little bit as we went through the implementation. Who's in charge of what? Add that to their job descriptions. Make sure people are trained on how to make sure that you are complying. Develop that call script. It was such an important tool. I really think it's critical in making sure that everybody understands what you need to ask to get to the meat of what we need to know. Of course, we want to maintain in the EMR as part of the clinical record, retain those documents, scan them in, however you're saving it. And then here's an important piece that I think we forget to talk about in compliance a lot is how is it actually working? Listen to your staff, check back in with your operations, your frontline staff members, and make sure that whatever processes you came up with are successful, that they can actually get that stuff turned around in the time frame that's required and people are receptive of it, however you're sending it. Certainly you want to think about HIPAA. HIPAA is a big deal and it's integrated in the fabric of everything we do. But when we have something new, it's easy to forget. So if you're using Gmail, you can't just send an email with a good faith estimate over Gmail because it's got PHI. So you need to make sure you're securing that, or you're sending it through a secure portal, or you've got mail that you're sending to them instead. You also want to make sure that you keep in mind your Section 1557 obligations in mind. That's the non-discrimination. So that goes back to language and accessibility. You want to make sure that you are communicating with patients in the language they are speaking and making it accessible. Posting on the website alone or posting a poster in your office is not necessarily making it accessible. You need to consider large print and other ways to make sure that people get the information that they need.
The actual Part 1 rules were a little bit more definitive about Section 1557. They just kind of alluded to it in Part 2. And I think by that reference in the context of the entirety of the law, I see clearly that it's Section 1557 enforced on the civil rights laws, non-discrimination, et cetera. So some reference points that we want to bring up here. Right now, under the statute, CMS will only enforce if the applicable state, the states are the enforcers. CMS was supposed to post a list state by state of the provisions that CMS will enforce if the state doesn't. And that list isn't out yet that we can find. We found an awful lot that CMS has published. If somebody finds it, please send us our way because it's MIA. And CMS will also enforce when a state lacks the authority. We pulled up when we were putting this together. I'm in Wisconsin, Mountain Land's in Utah. We pulled up the 2 state enforcement examples. So take a look. It's going to be in your state's insurance laws. Google in No Surprises Act for your Department of Insurance and take a look at what it might look like. Both of these examples look remarkably different. We went through them yesterday, but they arrive at the same thing. And they're going to talk about their enforcement and whatnot that's going to go on. And so any comments on that, Court?
No, I think you're accurate there.
Okay. And then for further information and discussion, because we're not including it in this webinar, remember we stuck to our knitting on the good faith estimate. We didn't discuss the dispute resolution. So that's already started. And we have the, the people that are going to do the dispute resolution, and they've been given their guidance. The further discussion is it's about convening provider. It's really not likely that a therapy practice, a rehab agency, or course a convening provider. And we'll get further information when the CMS final rule is published. This is a quick reference slide here to show you what the dispute resolution looks like on paper and through the CMS portal where you pay your $25 to get into the door. And I'm assuming you go to gov.pay to do it. We wanted to provide just a couple of quick examples of potentially of concern when you would or would not use a good faith estimate. A walkover splint. You're a hand therapist, the orthopedic surgeon's next door, the patient comes in following surgery, gets, physician checks them over and wants to send you next door or downstairs, wherever your therapy clinic is, for a walkover splint. Well, you're not a DME provider. So as if you're not a DME provider, you can actually issue an ABN for that and collect cash from the patient. So that's a perfect example of you don't have a day. When Courtney was talking about all those different day deadlines, it's a walkover splint. You don't know the patient's going to walk over from the orthopedic surgeon's office that day. Another example is dry needling or cupping. These are not Medicare covered services. So if it's a Medicare patient and the therapist does an evaluation and determines that dry needling might be very effective for what the patient's condition is, they're going to say to the patient, we recommend you have dry needling. It's not covered by Medicare or your insurance company. And they say, well, how much does it cost? That triggers for a good faith estimate. And also for Medicare, Medicare has issued a missive this week that dry needling requires a mandatory ABN. Then there's the old classic example of the patient scheduled for two times a week, and they say, I want 3 times a week. Well, it's not medically necessary. So you issue an ABN for the cash, but we don't know if the ABN can stand alone because it doesn't have all the good faith estimate items on it. Then also for workers' comp or auto, somebody comes in and they have workers' comp or auto. You're treating them like they're workers' comp or auto. What happens then, Courtney, when you get a message from workers' comp or auto that says we've denied that claim?
Yeah, and we see that, right? We absolutely see that. And that's when you have to figure out, you have to go back and determine if they have insurance that can be billed or if they are now self-pay. And if they are, then from there forward, you need to have a good faith estimate. You can't really do a good faith estimate for the past, but we do have claims for the past. So we want to provide that information to the payment, give them what they can expect if we determine that they are self-pay at that point.
Then we have unique circumstances when you get a Medicare Advantage patient and the Advantage patient has no out-of-network benefits. There's a great article in the PPS, APTA PPS Impact Magazine that goes over this. If you're a subscriber to Rick Goenda's newsletter, he has a great article on this that gives like 6 different scenarios of when you can charge, quote, cash, which would trigger this. And I think many of our NARA members provide contract therapy services to skilled nursing facilities. So they're, look to your skilled nursing facility for when you need to be involved in that particular process moving forward. There's a lot of unknowns that we still have. Do we have to provide both on the Medicare ABN? The ABN doesn't contain what we need to do on a good faith estimate. What about in those states where therapists are not allowed to diagnose by the Practice Act? And I think we mentioned earlier, is there a violation of an insurance contract? And that your insurance contract, probably if you're a contracted provider, tells you that you have to accept the insurance. You can't let the patient pay cash. If or not, you can do that. Or Courtney, I think this example came from somebody in your revenue cycle department. The patient decides to reverse course after they get their they've been using their insurance and find out what their copay is when they look at your website and find out your cash rate is cheaper. What happens?
Yeah, exactly. So sometimes they'll have a really high deductible. They get that first bill, they're paying, the full non-discounted self-pay cash pay rate, and they want to switch over. So yeah, that's a good question. We don't know where to go from there.
Right. And so you can't, you backdrop into it. So that process needs to be, taken care of and looked at in your process, because you don't want to be refunding money to the healthcare plan. Tell them to recoup the claim, reverse the claim, and then accept cash from the patient. Then, you've lost all your profit from therapy and all of your administrative costs, even if you don't know whether it's right or not.
And
So
I'm sorry, Nancy. There's
Go
also
ahead.
a complication that our rates for us are, again, our cash rate is our same day rate. So we don't offer that rate to somebody if we have to go through the billing process anymore.
Yeah.
That just complicates these issues.
And then we put questions forward to CMS, and that went through the PPS Payer Policy Committee up through the chain of command at APTA. And I'm probably not aware of other questions that have been asked by our other sister associations, but we're waiting for answers. And I'll just say it again, we all missed it. We all missed the interim final rule in the comment period on December 6th. And we don't know if this is just an unintended consequence or not that we're thrown in here. We do meet the definition of a licensed provider, but this is a tremendous amount of administrative burden, just acknowledging that. So, we're on board with that particular aspect of it. So we want to take some time for questions. The few remaining slides have contact information and whatnot. So Sabrina, what have we got?
Wow, that's what I want to start with is wow, Nancy and Courtney, that is a lot of phenomenal information, a lot of information, right? So a couple of things, I want to answer some of the questions that have come in, and I want to provide additional information for attendees. AOTA has updated their website. So if you haven't been on their website, I believe in the past week or so, they have updated it. There is a section for members only. So you will have to tap into your OT practitioner members. If you go to their website and you go to the careers/state-licensure and you kind of scroll down to the bottom, there is a section on state regulations, and there's a bunch of links there for licensure and laws, regulations, and that's where your members can assist you with that. So I wanted to highlight that. We also are recording today's webinar. The webinar will be available to all registered attendees. In about 48 hours, you will receive an email that will have a link as well as a copy to today's handouts. We will also be putting the webinar on our members portal that will also have the handouts from today's presentation. Nancy has done a phenomenal job of giving us all types of resources. So again, thank you so much. If you have questions, which there are a ton of questions coming in, as you both can imagine, we're going to ask that you type those into the Q&A. We will get to as many questions as we can during the few minutes that we have remaining. Any of the questions that we do not get to, when you type them into the Q&A, Christy is able to download those. And so we can get with Nancy and Courtney and Laura and get those answered, and we can send those out actually to all registered attendees as well. And then you will also have Nancy and Courtney's contact information. So now that I've covered the housekeeping pieces, let's get to what everybody's really curious about. So you've got some great questions. The first one, the CMS example of the GFE does not include a patient signature. Can we add a signature part just to prove the patient was given a GFE?
Yes, in fact, the form that I created that Mountain Land's using has an electronic signature on it. And if it, I've sent it to people, I've customized it for a few other people. And if they don't have Adobe Acrobat or one of the things that will show that electronic thing, it shows up as a box that you can use. Highly recommended. It seems odd to me that CMS wouldn't suggest that at least.
Courtney's smiling and nodding, so you're in agreement. I just wanted to see if you had additional comments. Next question. Section B.1.I. So if you have it memorized, inquiring if an individual is enrolled in a group health plan, ... In this instant, does the word inquiry just mean that we are asking the patient, or is there an exception of electronic verification?
I think what you're talking about is electronic verification of benefits through a portal, right? It's probably what the
Perhaps.
question is about. And I think that the definite, what we have in the law is what we have in the law. So we have to kind of take that, if a patient calls in and says that they, after you go through the algorithm, do you want to use your insurance? There's an expectation for people that accept insurance that you're going to verify insurance, but tell the patient that it's whatnot. So I don't, if somebody has insurance and is going to use their insurance and they didn't ask for a good faith estimate, a good faith estimate's not necessary.
What if for our self-pay patients, we do not use standard CPT coding? Instead, we have unique codes that encompass multiple services into one rate. What should we do regarding the quote?
So we actually handled that because we do the same thing by describing on our standard form for that type of service, all of the different codes that could be included under the one that will appear on the invoice. So we described both. We described what appears on the invoice, what CPT codes that correlate to, and what rate answers that.
And Sabrina, I think it goes without saying, those of us, and Courtney knows because we've been in discussions on the conditions of participation with respect to the mandate and the infection control standard F. It sort of seems like this is trivial. I hate to say the word trivial, but in the bigger scheme of things, with the potential issues that could happen, under the complying with the standards, if you have a rehab agency survey, and I had somebody had one yesterday in Florida. So, let's get on this and let's do our very best. And I think Courtney would agree with me that at the very least, get your website notice up, put it in your footer, put it next to your HIPAA notice of privacy practices, and link to a page that has the CMS templated language that they have a right to request a good faith estimate. That's the very least. And you should probably feel refreshed that you did something. Now, that's not a legal opinion. It's just saying you should feel just refreshed that you're stepping forward and you're making an attempt to be in compliance, moving forward.
And that goes right back to documenting what steps you're taking to be compliant. Just having that documentation is helpful if you do get a surprise survey before you complete the process.
Another question, and this will be our last question, is must we provide a GFE to a caller who is just calling around because they're quote unquote shopping for rehab services?
Well, I think that's one of the questions that the whole group of people we were working with had, because a lot of people do shop, especially if they know their insurance isn't going to cover it, or if they have a huge deductible and maybe their insurance doesn't allow the payments to go toward their deductible, all of those variations. And kind of the thing is, yes, they're asking for an estimate, and we don't want any rehab agency or one of our members being the first case where somebody files a complaint with HHS or through the portal. So,
okay.
And there was a question that came into the Q&A about the assistant pay cuts. So just to kind of let everybody know from a NARA perspective, as well as APTA, AOTA, NASL, and ACA. We are all meeting with the director at CMS shortly to talk about the assistant pay cut and the impact of COVID on therapy providers, as well as access to patient care. So if you are a NARA member, we will definitely be getting you an update as to what the outcome is from that meeting as soon as we possibly can.
Thank you for the update, Christy. We are very excited for this meeting this afternoon. So thank you for that update. On the screen, you do have the contact information for everyone. Thank you, Nancy, for putting that up. And again, thank you so much, Nancy and Courtney. That was an incredible webinar with lots lots and lots of great information. So thank you everybody for attending our webinar today and have a great day.
Thank you all. Our pleasure.
Bye.